Welcome back to my channel. I hope you've had an amazing week. This is GP Made Easy and I'm Dr. Daniel Follows. So today we're going to be covering Gastro-oesophageal reflux disease, or GORD as it's more commonly known, as it is quite a common condition in the UK and can be quite tricky to manage in some patients. So I'm hoping by the end of this video you'll know more about the condition and have a better understanding on how to manage it. Before we do, don't forget to like, comment and subscribe so I know that you're enjoying this content. So, on with the video! First of all, a little bit of background information about GORD. So it is defined as a chronic condition in which gastric juices flow up from the stomach into the esophagus. And I've got a diagram up here, which you can see sort of the stomach is down there and then it moves up into the esophagus, which is more commonly known as the food pipe. GORD is also grouped under an umbrella term of dyspepsia, which is the sort of discomfort and acid coming up, and there are different types. So the first type is the reflux type, where patients more commonly get the heartburn and indigestion. There's the ulcer type, where people are more likely got an ulcer, and this is where they tend to get the upper abdominal pain sort of around here. And there's also the dysmotility type, where the food pipe in the stomach isn't moving food as quick as it should. And the symptoms you tend to get with this are nausea, bloating and fullness. So going back to the diagram, the main theory behind what causes reflux is that the lower esophageal sphincter, which is here, which is when food has gone into the stomach, stops acid coming back up. But the theory is that this sphincter becomes a bit weaker, which allows acid to come back up. We like to get on top of reflux as the damage caused by the acid can lead to some patients developing Barrett's esophagus, which is a precancerous condition, and if it kept progressing could lead to gastric cancer. And it is estimated that about 12 to 28% of the Western population suffer from reflux. So it is thought that there are many different factors involved with GORD. So for example, factors that affect the lower esophageal sphincter are if it relaxes more frequently, if you have a hiatus hernia. So I'll pop a diagram up here, and that's where part of the stomach moves up through the diaphragm into the chest cavity. If there is decreased tension in that lower esophageal sphincter, and nicotine can affect it as well, as it can cause muscle relaxation. Factors that affect the esophagus or food pipe directly are if it has poor clearance of food, if the lining of the esophagus, which we call the mucosa, is more sensitive to acid, or if it has decreased resistance to acid, or if there is decreased saliva production. Factors that affect the intra-abdominal cavity or the stomach include increased pressure, as it causes acid to be pushed back up into the esophagus. The stomach can sometimes have acid pockets. Your posture can affect it. For example, people find when they bend forward or lay flat, it can make symptoms worse, as again that increased pressure that pushes acid back up. If there is delayed emptying of the stomach, if you're pregnant, for again that increased pressure, or patients who are overweight, as again that increased pressure. Factors that can cause increased acid production include lifestyle, so for example certain foods such as spicy foods. Alcohol can cause increased acid. Patients who suddenly stop a proton pump inhibitor can get a rebound increased acid production. We'll cover this more in detail later in the video. High calcium levels can cause increased acid, and rare conditions such as Soliger-Ellison syndrome. And other factors that may be involved include a genetic component, and as we get older that can increase our chance of reflux. So something to make you aware of, red flag symptoms to look out for, which can mean a patient will need a 2-week wait referral, include if they are any age and have dysphagia, and that is where food or drink gets stuck in the food pipe on swallowing, or if they're 55 and above with weight loss and either upper abdominal pain, reflux, or dyspepsia. So moving on to investigations, so you can get some bloods, but especially get a full blood count, as this will come in handy later on. And you can get a H. pylori test if you think it's necessary, but I'd especially get it if they are presenting with signs they may have an ulcer, or if they've got reflux with a family history of gastric cancer. And again, we'll cover more detail about H. pylori shortly. Moving on to management. So first of all, you would start with some lifestyle advice. So cutting out certain foods that trigger it, we'll cover that shortly. Decrease their alcohol intake, stop smoking, and advise them to lose weight to get into the healthy BMI range. Next is to advise them on certain precipitants to avoid. So for example, smoking, alcohol, coffee, fatty foods, spicy foods, chocolate can trigger reflux as well, and especially advise them to avoid late meals. So their last meal should be at least 3 hours before bedtime. And then next you'd move on to reviewing their medication. So up here I've put a list of all the different types of medications that can increase reflux. So there's some of the classic ones up there, such as non-steroidal anti-inflammatories, the antidepressants, the anticholinergics, but there are also some rare ones that even I didn't know about, such as like beta blockers, calcium channel blockers like amlodipine, opiates can. So have a look at that list and have a see for yourself. And if they haven't worked, then next you would move on to trying an alginate for at least a month. So alginates are the medicines just like here, just like the antacid liquid and the Gaviscon. I'll put them up here so you can see them in a bit more detail. And essentially what they do is they just neutralize the acid. And then if that didn't work, you would try them on a full dose proton pump inhibitor, or PPI as we call them, for 1 month. So how proton pump inhibitors work is they directly act on the stomach to stop it producing as much acid. So up here I've got a table and it's got some of the common PPIs and the different doses. So it's got the full dose for the initial treatment, and if they do respond to the treatment, then you try and reduce it down to the lowest dose that you can, and hopefully try and have it on a just as and when needed basis. So up on the table there's some maintenance doses as well. So if they're not responding to any of those treatments, then have a discussion with them if they may need referral on to see a specialist. But times that would automatically trigger a routine referral to a specialist would be if they're 55 and above with any of the following things: either raised platelets with nausea or weight loss or upper abdominal pain or dyspepsia or vomiting, if they have treatment resistant reflux, if they have upper abdominal pain with a low hemoglobin count, or if they have nausea, vomiting, weight loss, reflux, dyspepsia, or upper abdominal pain. Now, something to warn patients about is that 50% of people can still have reflux and a normal camera test. Now, if someone's been to see a specialist and all other conditions have been ruled out and they've been diagnosed with GORD, then you can add a nighttime histamine 2 receptor antagonist. The commonest one that we use is called ranitidine. And if their camera test showed severe esophagitis, then you would give them 8 weeks full dose PPI, and you may actually need to use the full dose as maintenance as well. And if anyone has confirmed Barrett's esophagus, then they need to go on long-term full dose PPI. Now, just some warnings about PPIs is they can lead to low magnesium levels, they can increase your risk of gastric infections and fractures, and sometimes they can lead to a rare condition called subacute cutaneous lupus. And as I mentioned earlier, some people, if they suddenly stop a PPI, can get rebound increased acid production, and this can last for up to 3 weeks from stopping. So it's recommended to reduce the dose by 25 to 50% every week till they come off it to help reduce this. and they can also take an alginate during that time as well. So moving on to H. pylori. So its full name is Helicobacter pylori, and it is a bacteria that can sometimes cause reflux. It's diagnosed by either a stool test or a breath test, and they need to have stopped a PPI at least 2 weeks before doing a test. So I'd either swap them to an alginate or a histamine 2 receptor antagonist. So if the test comes back positive, then treatment is what's called triple therapy, and that's where they have full dose PPI and 2 antibiotics for 1 week. So the first line antibiotics is amoxicillin with either clarithromycin or metronidazole. And if they're penicillin allergic, then I'll just give them clarithromycin and metronidazole. If their symptoms persist or reoccur after first line treatment, then first of all you would retest them to check for eradication. You'd repeat the test 4 to 8 weeks after initial treatment. They prefer you to try and get it as close to 8 weeks as possible. And it is preferred to do a breath test to check for eradication. But if that's not available, you can just do the stool test again. So up here, I've got a table with some of the different second line eradication treatments. So have a look for yourself. So finally, just another condition I thought I'd touch on in this video is what's called aerophagia. And this is where people get reflux symptoms because of having increased quantities of air swallowed. This can come from eating and drinking too fast, chewing gum, smoking, mouth breathing, or anxiety. Well, that's it for today's video. I hope you found it helpful and learned something new. Don't forget to like, comment and subscribe so I know that you're enjoying this content. And if there are any topics you'd like me to cover in future videos, then please comment down below and I will pick them up in future videos. I'm also on Instagram, so if you want to check me out on there, it's up here. It's the same name, it's GP Made Easy. Or if you'd prefer to contact me in a different way, I'm also reachable by email, and my email's up here. Well, I hope you guys have an amazing week, and I will see you in the next video.